Good afternoon, doctor. Very happy to welcome you back again in this Neuroendoscopy Society of India monthly webinar series. And we are here now with a new fresh episode, episode number 5, this star cast of international speakers coming in from Italy and Canada, and with our own moderators and experts from India. To coordinate today's session, we have eminent Dr. Chandrasekhar Deopujari sir, Professor and HOD Neurosurgery, Bombay Hospital Institute of Medical Sciences. Sir has been chairperson of WFNS, Neuroendoscopy and Neuroendocrine Committee. Sir is also a founder president of Neuroendoscopic Society of India, past president of almost every body of neurosurgery in India, starting with NSI, ISPN, ASPN, and ISNO. Sir has contributed innumerable research papers published in national and international journals. So we are very happy to have Dr. Deopujari sir as our coordinator.
Yes, sure.
This
Yes.
webinar has been conceptualized by the president of Neuroendoscopic Society of India, Dr. Suresh Sankhala. He is a consultant neurosurgery from Mumbai, India. President of Neuroendoscopic Society of India, past president of Indian Society of Pediatric Neurosurgery, past president of Indian Society of Neuro-Oncology, past president of Skull-Based Surgery Society of India, past president of Bombay Neurosciences Association, and he is also a founder editor journal of neurosurgery publication papers. He has published more than 123 papers in various journals. He has contributed to 24 book articles and edited 2 books. So very happy to have Dr. Suresh Sankhala as today's moderator. Then we have Professor Ashis Pathak as also a moderator, Director of Neurosurgery, Fortis Hospital, Mohali, former Professor of Neurosurgery in a prestigious institute, PGI Chandigarh, former Consultant Pediatric Neurosurgery in NHS UK, Sheffield, former lead Vascular, Pituitary and Skull-Based Neurosurgery, NHS UK, Kingston, past President of Cerebrovascular Society of India, Honorary Secretary of Neuroendoscopic Society of India, former EC member of Indian Society of Pediatric Neurosurgery and Neuro-Oncology. Now I hand over the session to Professor Ashis Pathak to take it forward. Thank you. Before that, I will just introduce our company.
Go ahead.
I'll not take much time. This initiative is coming to you through DigiNeuro from Health & You Therapeutics, a joint venture with New Link Company Limited, Japan. We have a vision of fulfilling unmet medical needs by launching innovative first time in India products like Amnurite, Amitriptyline plus Mecobalamin, Amnurite 5, 10, 25 for neuropathy and migraine. We have Amnurite Beta, first time combined Amitriptyline plus Propanol SR for migraine when one drug is not enough. Amnurite Beta 520ER and 1040ER. The first pharmacological combination of Amitriptyline plus Pregabalin combined together, where Pregabalin is made in a sustained release form to match pharmacokinetic profile of Amitriptyline for moderate to severe neuropathic pain. We have our Mecobalamin injection imported from Japan to give you highest quality Murite injection. We launched first time in India 2.5 milligram strength of clobazam to give you flexibility of down titration, up titration and BID dosing. Adclobaz 2.5, 5 and 10 in mouth dissolving tablets. We have recently launched vitamin therapy for migraine on the recommendation of American Academy of Neurology and American Headache Society, which contains riboflavin 200, magnesium 200 and CoQ10 10 milligram. Brentamine, a vitamin therapy for migraine. As I was saying that all our webinars and more than 42 of them in neurosurgery itself are available on our YouTube channel. The channel name is DigiNeuro. So if you type DigiNeuro on YouTube, you will get a host of resources of neurosurgery illustrated by leading Indian and international speakers. So please go through this channel, subscribe it, like it, and you will get updates for next webinars from here. So thank you very much. Now I hand over the session to Dr. Professor Ashis Pathak.
Thank you very much. We are now on the fifth webinar series organized by the Indian Society of Neuroendoscopy. I would thank Dr. Suresh Sankhala, the president of the society, who has conceptualized this webinar, and it's going very well, and I think people are benefiting from it. Today, the session is more unique in the sense that Dr. Deepu Banerjj has organized this specially with three renowned speakers in their fields, Professor Domenico Solari, Professor David Locatelli, and Professor Fred Gentilli. Now, we have an interesting list of neurosurgeons who are the moderators today, and they are all eminent in their fields. First of all, it's a privilege to introduce Professor Deepu Banerjj, who is a senior consultant neurosurgeon in Jaslok Hospital, Mumbai. He had a long stint of experience in various important and renowned organizations in the country, which starts with National Institute of Mental Health and Neurosciences, Bangalore, then as a professor in SG Sanjay Gandhi Postgraduate Institute of Medical Sciences in Lucknow. Then he was also director of neurosurgery at Fortis in Mumbai and director of neurosurgery at Narayana Super Specialty Hospital, Gurgaon. Apart from that, he has been the president of the Neurological Society of India. He has been the president of the Skull-Based Surgery Society of India. So he is quite renowned for his expertise in the field of neuroendoscopy. No less important is Professor Prakash Nair, who hails from another prestigious institute, which is the Sri Chitra Tirunal Institute of Medical Science and Technology in South at Thiruvananthapuram. He did his fellowship in neuro-oncology, and then of course he has fellowship in minimally invasive endoscopic brain and skull-based fellowship at Weill Cornell Medicine, New York, under the mentorship of Professor Ted Schwartz. His areas of interest are endonasal and open skull-based surgery, pediatric and craniofacial surgeries. So we welcome Professor Prakash Nair as a moderator in this session. No less important is Professor Sukhdeep Jhawar, who is a senior consultant of SPS Apollo Hospital, Ludhiana. He has been a faculty in the Christian Medical College, Ludhiana, and he has got the experience of being a fellow, doing his fellowship in endoscopic skull-based surgery at Pittsburgh, USA, microvascular fellowship in Fujita, Japan. He has got special interest in cadaver dissection, white fiber dissection anatomy, skull-based surgery, and neuro-oncology. So welcome, Professor Sukhdeep Jhawar. We today, of course, will be missing our fourth panelist, who is Professor Ari Chacko. Unfortunately, because of some problems in his family, health issues, he will not be able to join us, but he was another eminent person who has got vast experience in endoscopic skull-based surgery, vestibular schwannoma surgery, and surgery of eloquent areas of the brain and spinal cord. And of course, we have Professor Chandrasekhar Eknath Deopujari, who is well-renowned in his field. He's the president of the IFNE, past president of the Indian International Society of Pediatric Neurosurgery, Indian Society of Pediatric Neurosurgery, Skull-Based Surgery Society of India, Cerebrovascular Society of India, and Indian Neurological Society of India, and Indian Society of Neuroendoscopy. So with this introduction, I now request Professor Deopujari to take over and take charge of the situation and carry on this session. Thank you.
Sir, please unmute yourself, sir. Yeah.
Thanks, Ashish and Suresh, for your kind words and this opportunity to moderate a session. These are strange times. I mean, cancellation of our meeting, which was to happen with interim meeting of the IFNE in Hyderabad, brought this idea that we should probably do either a virtual meeting or a series of webinars with our colleagues in India, and some of them who had sort of promised to come for the interim meeting of IFNE. Dr. Sankhala thought, rather than doing a cluster within a day or two, we should probably plan a year-long program to go to the next actual meeting. And that's how these programs have been arranged virtually, every month. I'm very sorry that this time may not be very convenient, but this time suits the Indian and Asian participants, which are the target audience we are looking for. And therefore, I really uh, 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 sort of thank our speakers for indulging us at inconvenient time. Without much further ado, I would start the day's proceeding by introducing Domenico Solari. He has become a friend of India over the years and a personal friend as well. And is a young, dynamic, he's assistant professor at the moment at the Federico II University in Naples with senior professor Paolo Capabianca, and has immense interest in this pituitary and endoscopic skull-based surgery field. And he is going to talk to us on large and giant pituitary tumors today. I think Domenico has done a lot of anatomical work, as well as Sukhbir has also done it from our side. And I'm sure he will give us some insights into how their surgery has developed and give us some idea how we can better manage our patients. Domenico, please.
Good afternoon to everyone. Good morning to the western side. Thank you, Professor Pathak, Sankhala, and Deopujari for having me here. It is a real honor. I will start immediately sharing the screen and to speak about the experience we had in my department with Professor Capabianca in Napoli about the treatment of endoscopic pituitary adenomas, giant and large. So, Professor Deopujari already told that I come from Napoli. This is one of two deities. Like, one is the volcano that is called the Vesuvio. The other one is Federico II, to whom is dedicated our university, and it has been like founded in mid 30th century, and it was the first public in Europe. And then, like, my tribute personal to this other deity that disappeared recently. And so, according to the evolution that has been in pituitary surgery along the last 70 years, but even before, we started our process of learning, like first with microscopy, first with microsurgery, and then we moved further. You see many people, like very famous people like Cardi here, like in Guyot here, and finally to the final position that is like the endoscopic. And for us, it has been a real journey, starting from
when we focus on equity and the importance for all of us to work towards greater health.
Hello? Is it okay? You hear me? Yes. Okay. So only to afford like that pituitary surgery, it has been like a really long journey, and it gets evolving day by day. And the only thing that we can do, like dealing with this field of neurosurgery, is standing on the shoulder of the giant, as in the myth of Orion. So we stand on the shoulder of a giant, and one of our giant to refer to was Professor Laws, actually working in Boston. And today is claiming that the transsphenoidal route, either performed by microsurgical or endoscopic approach, may grant the all pituitary adenomas. So again, like the giant has been fundamental for us, because when we started in Napoli in 1997, like already the duo from Pittsburgh, Dr. Joe and Dr. Carrao, has been defining what were the rule of endoscopy and what were the rule to achieve exposure of sellar and pituitary adenomas. That was first publication that came in regards by our school. It was led by Professor De Vicis at the time, but Professor Capabianca wrote this paper. And our concept is to not use from the beginning this transsphenoidal retractor that we were familiar with as neurosurgeon. So this is the door, because initially we started looking with the endoscope, that was a tiny instrument, and to avoid extreme difficulties that a neurosurgeon can encounter along the nasal route, and to enter this beautiful world of the pituitary gland, rich of vessels, rich of nasal, rich of very nice structures. And that was one of the first publication I had the honor to participate with, and it regards pituitary surgery. It is 3 moments, all of them are fundamental: the nasal, the sphenoid set, and then the sellar step. And when you look at the final portion of this kind of surgery, you have to be prepared, like to enlarge your horizon, embracing which are the suggestions that do not come only from neurosurgeon, but also from our contingent specialties, because it is a very, very multidisciplinary attire that leads you to the success. And this is only like few papers to witness that recently, like also the pathological definition of adenomas might be changed with this definition that is PITNET, of course, pituitary neuroendocrine tumor. There is some other interesting things about which are the factors that we should analyze to have a prognostic opinion after we remove the tumor. And finally, it has been also redefined what we call atypical adenomas, an adenoma that is not round, it is not soft, and eventually enters like the skull base. And this is our famous endocrinologist at Federico II, she's Anna Maria Colau, and also taught us how to deal gently with the hypophysis, because you see here a very short video. It is not only a matter of removing the tumor that usually is soft, like in this micro pituitary adenoma, move it toward the right side of the sella. Here we have like the gland probably, but with the endoscope, if we move further, we can close to this area, and you see here like this is the gland, and it is perfectly respected with all the vessel, and you see it is reddish to be like ready to work again after recovering. And this is the series that we performed so far in Napoli. Again, we started 1997 and we passed like to 2000 surgery, and most part of it have been like the pituitary adenomas. This is the actual instruments that we are working with. We tried also some other tricks along our route. First of all, the 3D. You know, like the endoscope has been many times pointed as a lacking of depth, like one should adapt, like should work at the middle. So we had like our experience with this 3D experience. That was one of my first case with this instrument, and we call it a very simple case, like probably a cystic lesion. Here you see a very tiny intrasuprasellar, and the video stopped, of course. You see here, it is opening like this soft, and then this bleeding. You cannot see the 3D because this is not a video recording in 3D, but it was like started bleeding when we move it toward the left side of the patient with a round knife. So it was tremendously threatening for us to stay at this venous bleeding, but at that time with the 3 glasses we thought it can be also the carotid artery. So we moved further. This is other instruments, very nice, and we backed upon like a solid group, because you see we are using nowadays surgery for this kind of adenomas. You all know, like SCTH adenomas, GH adenomas, of course, like in case of pituitary apoplexy not responding to high dose of cortisone. And we also move a work again that we had the opportunity to have with the Dr. Laws, and you can use this as indication to the bulk. It is not a matter only of having total removal. You can also enter the surgery to give some benefit to the patient, like decompressing the chiasm of the oculomotor nerves. And you see here another case that I can show you, a very nice round intrasuprasellar case. I'll show you very quickly, like very large opening, soft tumor, but again, you see, it is not important like only to remove the tumor that is very, very soft and it's easy to recognize. Here on the left side of the patient, we are looking at the gland. So here at the end of the procedure, like you see, very nice gland, and you see the suprasellar cistern that has been not breached, so only like hemostatic materials, and this is a tiny piece of mucosa that we get off the middle turbinate removed as surgery. So this means like that is very fundamental to look with the endoscope to get closer to the problem. This is a paper coming from the group of Dr. Kelly in Los Angeles, and you see here how nice you can improve the removal as long as the dimension of the tumor enlarges. So you will achieve extra benefit by using the endoscopic endonasal corridor because you recognize exactly what you're doing, exactly the structures that you are dealing with. And so these are the best advantage that we found in surgery and for the patient. And this is again, like what we moved before, because today we have to expand our horizon to deal with the giant or large pituitary tumors. And this is the common indication when we talk of giant or extended approaches in endoscopic endonasal surgery. And basically, this approach is probably the most common to deal with adenoma, that is called transtuberculum transplanum. It has been used a lot and is still used for craniopharyngiomas and several tuberculum cell and planum meningioma. You see, there is not anymore the opening only of the cellar floor, but you can expand your opening of the bone and the dura above. These are tiny reminders, very tiny reminders of what you are doing, because you have to achieve the correct space to enter the supradiaphragmatic space. You have to deal with not anymore intracellular structures. There are vessels, there are nerves above there, and you have to respect also the tiny vessels of this area. This anatomical reminder, again, like of the corridor that naturally can be transgressed with the endoscopic, but basically are depending of the lesion, because the lesion has been expanding toward one or other side, and you will follow the lesion again in the suprasellar space. This is our first publication in 2011, and these are several cases of the extended corridor for a large. You see, the first case, it is not anymore a giant pituitary adenoma. It is a recurrent case and extends in the suprasellar space. And you see here, why we are showing this? Because the tumor breached out to the diaphragma cell. So you can see here above the optic nerve on the left side, might recognize here the pituitary stalk, but it is not yet an adequate exposure. You have to dissect the arachnoid from this, that is the capsule. You see here, like this is the intracellular space with a cotonoid inside, like a wide opening. Again, you see here the stalk, and finally the anterior complex of vessels, the tiny vascularization of the chiasm, and then you have to reconstruct as an extended approach. Again, like this is very nice to recognize that we pointed out as the stalk and the residual gland above it. What we gained with this starts to be a large or giant. The noticeable part is this color that the diaphragm caused, and this part inside the supradiaphragmatic space completely separated from the intrasuprasellar aspect. Again, here we started with what we call it like a double corridor. We deal first with the intrasuprasellar part. We did not yet open the suprasellar space here, like we have only decompressed the above of the tuberculum. Then we had like the breach of the diaphragm, and we go over and we open the dura here, biting a lot and respecting the diaphragm, so we can start dissecting the supradiaphragmatic space, and we can go little. You see here, like still soft tumor in that part that was completely separated. It comes out very nicely. You have here the diaphragm and the gland, and you have the chiasm here, and that was the impinging of the tumor inside the suprasellar space, tiny coagulation, and again, like exploration with the scope. You see the basilar heart in the retrocellular space, the mammillary bodies, and the third ventricle floor. This is the post-operative control. That time we used like a multi-layer reconstruction, like plugging a lot of material inside the sphinx sinus. But what we experience with this tumor was that there is tiny difference among this kind of tumor and this other kind of tumor. You see, because when a giant or large pituitary adenoma has breached out the diaphragma, it is not anymore about the dimension of the big axle. It is a matter of what you're dealing with, and sometimes, although it is a soft and round tissue, you will have several conflict with vessels, several conflict with brain tissue. So here is a very initial case that we performed in our school, again, like by manual technique, lot of removal in the intracellular space, the diaphragm with the residual gland, and then when you're dealing with the with the arachnoid tissue, you might recognize here the right optic nerve starting again, like following the tumor, and you see here you enter inside the third ventricle and you have a lot of blood and you have to unclog the third ventricle, otherwise you'll get into hydrocephalus. So this imposed us like what we call like the adaptability concept. We have to follow the lesion. It is a nice tumor, it is a soft tumor, but what if you have this kind of situation? It is not anymore again a problem of dimension of the tumor, it is an unconventional adenoma. So you have to be prepared to think unconventional. It is not anymore like a regular surgery that you go in and you go out immediately, like a very boom boom surgery. You have to be prepared to do your best, like as in a transcranial surgery, and to respect the arachnoid and all the cleavage plane. So this is our series, like just a proportion in between what we call like conventional intrasuprasellar adenomas and unconventional pituitary adenomas that breached out the diaphragma and just entered the supradiaphragmatic space. And here also like a very nice figures that show that shows how difficult it is like to achieve gross total removal in these cases. And here I show you again this case, like that was again a recurrent tumor in a 30-year-old ladies, and you see like maybe you have like 4 centimeters of maximum diameters, but you see this bulging and this impression over with a cyst and these bulbs of tumor pointing to backward toward the third ventricle. Again, in this case, it is not allowed like to have a double corridor. You have to open the tuberculum cell and you have to open widely the dura to explore and to recognize the dissection into supradiaphragmatic space by manual dissection. Again, with these blunt instruments, you dissect the tumor from the arachnoid. You did not yet recognize, we did not yet recognize the optic chiasm. The tumor is soft as well. And this is the brain parenchyma here, the brain tissue. So we followed the tumor up to the brain tissue. We start again to dissect the arachnoid, and it comes the right optic nerve in this part, the left side of the vessels, of the anterior complex of the vessels, and sharp dissection. And again, like we enter, like after removing tiny arachnoid to the other part, like the most lateral aspect, and this is the final view with the nerves that are completely displaced, and this is the anterior vessel complex above the chiasm. It is completely distorted by the growth of the tumor. Again, like this tumor may be nice up to the most anterior part, but if you look at the posterior aspect, it enters behind inside the third ventricle. It is quite large and it goes up, and you see here in the video, we started dissecting again, like we opened the tuberculum cell, we're just coagulating the superior intercavernous sinus. We respect the layer of the gland above that you saw on the most superior and lateral aspect. And we are removing again from the arachnoid, like you might see here the stalk. This is the right optic nerve. We are working superior and lower to the stalk. We are using also like the ultrasonic aspirator in case like we have strong adherences, and you have to not pull again like in regular other tumor. And that was the third ventricle. It was collecting our blood, our venous blood coming of the tumor, and as long as we slide inside, we can recognize the final aspect with the gland here coagulated and the cavity that has been freed by the blood. And the final MRI at 3 months, you see here, like completely respected, tiny bulging of the most anterior part of the third ventricle, but not any problem. And what in this case? This is a very tricky case. Like again, it is not like a regular tumor that stands up here and impinge the chiasm or move off the nerves. It enters the brain tissue and it has several cysts. You see here, like also this white cyst. Maybe it can be performed by via transcranial route, but we thought that the cyst will be pinched by the endoscopic endonasal route and the tumor will be completely removed. It was a recurrent case. You see here like a wide opening in between the carotid. You are not seeing here, but we performed it with the neuronavigational system and the tumor was soft, fortunately, because it was a recurrent tumor. And you see here, like that was the part of the cyst. That was the part inside the third ventricle. We are seeing it again. Like we've been very lucky in this situation because the solid part was, that was the part. Okay. You see here, I missed the video. That was another video. Okay, so I show you the complications that are quite different as compared to the other standard or extended pituitary approach, and these are that we reported so far among 75 cases that we performed so far. Like, of course, for this kind of surgery, the most threatened and common presentation it is the CSF leak, but also this other issue that you have to deal with when you are dissecting the arachnoid, that this is the vasospasm, because when you are detaching the tumor from the vessels, it might happen that lately on the night you can have like vasospasm of that tiny vessel. And as you see also in the video before, like sometimes you have to use like also an agent corridor. That was the case of before. I'm sorry for that. Like that case has been performed with a double corridor. So in that case, you might open also transcranial supraorbital corridor and use the endoscope to push with a double corridor to push the mass of the lesion that is far off the midline, pushes inside toward the midline and remove the tumor from the nose, and then help the reconstruction part to see how it is in material. So final consideration for what we have learned so far with dealing with this kind of tumor, and of course that you will encounter like a distorted anatomy of the suprasellar, supradiaphragmatic space, and you have to respect it and you have to recognize properly every kind of structure. Then you have this problem of the bleeding, because when you are like not anymore protected of the pseudocapsule of the tumor, the mass may bleed a lot, venous bleeding, and if you leave back something that you cannot achieve, that you cannot access via the endoscopic and nasal route, then there is an extreme higher risk of infarction of the tumor, of swelling of the tumor, and of course severe consequence, because it will happen in the supradiaphragmatic space and sometimes inside the brain tissue. Of course, we saw that complications are far away high as compared to regular pituitary surgery. And then our opinion is that you have not to go to the war without the proper instruments. There is no opportunity that your pituitary instruments, designed and all functional, may help you if you are working upside in the third ventricle, or you are working inside the arachnoid space, or like lateral toward the supraclavicular space. And finally, only like to remind that the problem is still that when you perform like a wide opening of the skull base, you have to reconstruct it. And I showed you like that the first case were made like in a multi-layer reconstruction or with sandwich technique. What you're using today is called the 3F. We just put some fat inside here, the breech, we fix it with the glue. The fat works as a cork. It comes out if you tilt up the table, and it will clog the osteodural breach, and then you cover with a flap, and then the day after the patient stand and reduce the intracranial pressure. So another very important concept, that you have to develop the pituitary center of excellence when you deal with this tumor, not because you are, but you have all the people that are written down here again by Dr. Loos and his fellow in the United States. You have to have all that figures that cooperate to achieve the success of this part of the tumor, of this surgery. And this is the European definition of the Pituitary Center of Excellence. And this is our consideration, because again, like you have to dance again in a team to achieve like a wonderful job. And this is our report that came out in 2016, only to show you that also with adenomas, like things slightly changed, because you can see here like that the volume of total centers in Italy has been completely changed also for adenomas, and the transsphenoidal endoscopic approach represents the 70% of the actual procedures that are performed. Still, it is not yet over, because radiomics and new therapies are just coming out. So probably we have to study again and to reschedule our surgery in order to achieve first like the proper neoadjuvant treatment. And I think it's all. Thank you very much.
Thanks, Domenico. That was a nice tour to various possibilities while treating a large and a recurrent tumor. And I'm sure there will be a lot of questions, but please keep them for the discussion at the end. And I think I'm very, very concerned, and very importantly, you talked about, post-operative pituitary infarction if you left some tumor, which can be as disastrous a complication as the bleeding itself. So I think I'm sure the other panelists and would also give us their ideas as to what is actually the adequate excision in such patients. We now move over to the other kind of tumor, which has become amenable to endoscopic transsphenoidal approach, especially with the extended approaches, and has given us much better results in some of the tumors which were otherwise difficult to approach by transcranial corridor. And I would like Professor David Locatelli, who is a professor of neurosurgery at the Inserbia University at Varese, Italy. I think it's in the Lombardy region, very close to Milan. And he's recently written about the COVID experience as well, where it actually originated in Europe, and the effect it has had on transsphenoidal surgery. But today he's going to talk to us about his experience with craniopharyngiomas. David, please. He also works with a very esteemed colleague who's very well known in ENT circles, Paolo Castelnuovo. I'm sorry for if I am pronouncing it wrong, and who has also developed some orbital approaches, etc. But that is for another day, I think. David, please.
Thank you very much. Okay. Can you hear me?
Yes.
Okay. Thank you for this invitation, and I am happy to be with you and with Chandra, with all the Indian friends. I've been to India some years ago. I will be happy to come again in the next future. But today we have to talk about the craniopharyngioma. So I think we have to being confronted with this difficult tumor. This difficult tumor is something that has very special characteristics. It is aggressive. It is adherent. It is very important from the endocrinological point of view, as high tumor variability, and we have to tailor the treatment for this tumor. In any case, when we are confronted with a craniopharyngoma, we have to consider a lot of problems. First of all, quality of life preservation, then risk of recurrence, then age allocation, then adhesion to hypothalamus, and which are our chances to attain endocrine function preservation, and when and how to apply radiotherapy. So endoscopy is just a piece of the craniopharyngioma puzzle. We have many topographical explanation of how to treat this tumor. We know all of them. Obviously, are very interesting, well done. But the pros are that the relationship with pituitary stalk, optic nerves, and the hypophyseal axis are well explained. But the cons are that craniopharyngioma may extend into multiple regions. They are difficult to predict. It is difficult to predict the exact relationship between craniopharyngioma and the third ventricle, difficult to predict hypothalamic iodations, difficult to understand the exact site of origin, and many topographical error may lead to erroneous surgical approach. So we need to know exactly which are the problems with the hypothalamus, and when we are confronted with this tumor, we have to take in account these different topics. First of all, growth pattern, then age, clinic, primary or recurrent tumor, previous radiotherapy. And then we have to take in account many predictive factors like position of hypothalamus, position of the stall, presence or not of calcification, shape of the tumor, and some factors which are a predictor of post-operative problems. And then we have to decide what we should do, because we have different technique we can apply, we have different route we can use, we have objectives which are not always the same. Are we aiming to toward gross total or subtotal resection? We are aiming toward stage therapy. We are looking for a combined therapy, radiosurgery, other type of therapy. Well, it is like a pendulum. We have different options. Radical gross total resection. Obviously, we will have less relapses, but we risk much more hypothalamic dysfunction, pituitary dysfunction, and quality of life worsening. We are aiming toward conservative subtotal resection, less complication, but more operation, and sometimes the long-term results are not the same. Multimodal therapy, okay, subtotal resection plus radiotherapy, secondary effects of radiotherapy, adhesion scars can give a bad result at the end. So what are our suggestions to manage this tumor? This time we will discuss only about the approach from below and when to apply this type of approach. And which are the advantages of this type of operation is that the brain retraction obviously is obviated, direct manipulation of the optic apparatus, you can see easily. Tumor removal can begin immediately after opening the dura, and we have probably less risk of visual worsening. And you can see that we have also the option to go from above when we have a cystic tumor, where the cystic tumor is mainly cystic. We will see when we apply an endoscopic transcranial approach. So the transcranial approach is aimed toward treatment of a pure intraventricular cyst with a moral obstruction, with hydrocephalus. And we have many type of technique we can use, like resection, cyst stenting, cyst fenestration, intracystic therapy, septostomy. And obviously we have the other option in a staged way. So is this something new from the point of view of surgery? No, it is always a microsurgical operation, because anatomy is always the same. It changes, obviously, the way of seeing it. So this type of pictures is better seen in an endoscopic approach than in a classical microscopic approach. And obviously, when we are inside, still better because we can see perfectly all the vascular and the neural structures with very precise visualization. So we can be confronted with a prefixed and with a postfixed chiasm, and we can have the best approach from the nasal approach with endoscopy. Let's see some clinical cases to make clear what we mean in this case. This is a case in which we are confronted with a classical adult craniopharyngioma. In this case, no problem. We go for direct approach, endoscopic endonasal. In this case, we have hydrocephalus, and so before operation, shortly before operation, we put our Meyer cell replacement, we open the cyst, and then we go for the operation. And the operation is, I show an example of this case. We have obviously to take in account the closure of the intercavernous sinus. We have to pay attention. I would like to point the attention, turn the scissor, avoiding any risk of injuring the ophthalmic artery, because sometimes is in a different position than you can expect. And then you have to work inside. Work inside today with Sonopet, with CUSA. You can have a better control of the tumor without exerting any traction. And the only traction you can exert is with a double suction. Then we go for with diving technique we use always with tumors in this region, pituitary and craniopharyngioma. You can work inside the ventricle, and then you see that you have exposed the anterior communicating artery, the A1 for both sides, but then you can see the foramen of Monroe, you can see the previously placed stent inside the ventricle, and then you can check the different structure, P1, the basilar in the posterior part. So this is a post-operative 2 years after, and this is a classic tumor. But in a tumor like this, it's almost everything is cystic. Would we go from the transcranial endoscopic approach? No, because we have no hydrocephalus. Better to go from below. In a case on the other side in which we have no hydrocephalus, but it is a child, and this child has a big calcification lump that in a previous before new tools was quite difficult to take out because the lumps are completely fused together, and we need very careful work with the CUSA to destroy the adhesion between the different lumps. Then we go around the part of the tumor, okay, and then we dissect the part of the tumor which is amenable from below, and then again we dissect the calcified part, and very gently we can dissect the tumor from lesions, and at the end this tumor could be can be treated from below, also if it is quite big, the extension above, with Sonopet, with careful dissection, and with diving technique. So you can see the final vision of this tumor resected inside, and this is the post-operative 4 years after the operation. what else to say? Other different type of cases. In a case like this, 11 years old, puberty is not already obtained, so we can gain time treating these tumors with cyst fenestration and positioning of Maya, waiting for the best treatment. Or in a case like this, very huge tumor with a big with hydrocephalus, we go for an endoscopic transcranial cyst fenestration. You can see the foramen moro completely occluded from the tumor, and we can empty the tumor, again time, and not try to take the tumor from this side, but just to void the cyst, and doing it in a staged way, empty the cyst, look for the other cyst that is inside on the contralateral part, delicately suction, and then open the second membrane. Here you can see, and opening the second membrane, complete emptying the tumor, and having time to give the best result with a second operation. In a tumor like this, another technique, in this case we use the laser to resect a part of the tumor which was coming out from the foramen of Moro, and then we put a stent inside to gain time, and to have time for another operation in a later time. In a case like this, a combined approach, because the tumor was had already been operated 3 times in South America, and the adhesion were so firm that the simple operation from the endonasal, from the single operation from the endonasal approach was not possible, and we needed a combined approach. But in a case like this, why not going from behind? Because it is useless to open the nose to go. This patient had been already operated in another hospital, but the recurrency was in posterior fossa. And in this case, for me, the possibility is not to go again from anterior approach, but go from posterior fossa approach, classical, without or with, as you prefer, with endoscopy. In a case like this, a staged operation in which we see that the tumor had been operated in another hospital before the puberty with a craniectomy, and the tumor was resected partially. The part in the cella was left, and the part in the hypothalamus was left, but we gained enough time, and when the patient came to our hospital, we were able to take the tumor. It was more difficult than a primary resection, but you see, in this case, after opening the posterior wall of the tumor, we can go inside the ventricle, and using the diving technique, pump back the tumor toward the exit, and be satisfied with our final result. And this is the MRI after 4 years of this case, and you can see the stalk is still conserved. Another case in which we did the same staged operation, and what about the stalk? The stalk is always a problem with scleropharyngioma. Before I finish, I want to give my opinion on the stalk resection, because 15 years ago I did this operation. Was one of my first endoscopic endonasal resection of craniopharyngioma, and I always operated from above before, and I was very attentive. I was looking for the pedicle. I was able to understand it was inside the tumor, but I could dissect the tumor quite attentively, and spare obviously all the vessels inside. And at the end, it was possible to see that with microsurgical technique, freeing the tumor from the adhesion with a sharp cutting. It was possible to take the tumor and to, having seen the position of the stalk, you will see in a few seconds, here it is, the tumor, the stalk is there, the tumor is completely dissected from, and the stalk is conserved. And this is the endoscopic diving technique after finishing the operation. And okay, very nice. And I went on with this consideration for the next 10 years. 5 years ago, I did this. The stalk was almost invisible. The stalk was invisible, but if you look very with a near vision, you can understand that there are very few fibers. But at the end, after taking the tumor, you see the stalk becomes again the normal width. So you can see that the stalk is conserved and the tumor is resected. And in this case, very satisfying case, you see the tumor is completely resected. You can see the stalk, the diving inside the ventricle. It's okay, and the patient no problem with the endocrinological function. But case exists. More recently, in a case like this, I looked very attentively for the stalk, but the stalk inside, I could not decide where it was, and the stalk was completely divided in many single layers all around the tumor. So I think today that in this case, some selected case, you need to resect the stalk, because otherwise, if you do the great surgery of preserving just the imaging of the stalk, but not the function, probably you may render worse the hypothalamic function by tractioning, trying to preserve something is not functioning. So in my opinion, when the stalk is completely invaded, it is not possible to divide the stalk from the tumor. Better to resect sharply and go for a complete tumor resection if the patient is after puberty, obviously, but you can delay this problem as much as you can. So to finish this post-operative of this boy, different approach. This case, big tumor coming inside the third ventricle, first operation, endoscopic transsphenoidal, in my opinion. This case looks similar, but invasion of the meningeal layers. Many operations before, 3 operations and radiotherapy. Useless to go from below, because the dissection of this tumor is much more difficult from below than above. So, in my opinion, in this case, terminal transcranial still have a good role in this resection of this tumor. And obviously, my suggestion is in pediatric craniopharyngioma, stage surgery, if possible, to achieve a normal psychophysical development before an attempt to radicality. Quality of life has to be our guide to the treatment in both adults and pediatrics, but remember that anytime you leave the tumor, it will come back, and you have to balance very cautiously which option you have to be confronted with. Thank you very much for your attention.
Thanks, David. It was again a very comprehensive review of how do you choose patients as well as the technique of surgery. And I'm very happy that you have also started believing in stage surgery, which has been our philosophy for quite a few years now. I think the questions are coming at the end. So I would take this opportunity to introduce Fred Gentilli, who's the clinical professor at the University Health at Toronto, and he is the director of the Skull Base Center, and he has quite a prolific publications as well as experience and in various skull-based procedures, open as well as endoscopic, which has currently become his main focus. And he's already published something on anterior skull-based meningioma, but let us hear from him what he has to talk about, how his thought process has evolved and the technical nuances. Fred, please. You are probably muted, Fred.
Yeah, unmute yourself.
Yeah.
Okay. Can you hear me now and see me?
Yes. Yes.
Okay. So I want to first of all thank Professor Sankhala, Deopujari, and Pathak for organizing this. I think in these turbulent times of this pandemic, I think these educational webinars that you are doing are very, very, very useful. You know, we can't meet, but I think for young neurosurgeons all over the world, they come to me and tell me how important these are for them. So thank you again, and thank you for inviting me. So my talk this morning is on suprasellar meningiomas and the role of endoscopic techniques, looking at some of the indication, limitation, and see if we have some results. So this is our series of expanded endoscopic approaches, our Toronto series. You can see we're almost 600 cases now. These are all expanded procedure. We've done almost 2,000 pituitary cases. So our total thing is about 3,000 cases of endoscopic surgery. And you can see the pathologies. We had a beautiful talk just by Professor Locatelli, Pituitary, we have from Domenico, and today I'm going to talk on meningiomas. Now, there's no question, no one would argue that endoscopy has made a major contribution to skull-based surgery. In some places, it has totally replaced the open approaches. These are paranasal sinus pathology, benign interdural lesions, encephalocele CSF leak. I've not treated a CSF leak open now for a decade, 10 years. These are all can be done, all using endoscopic techniques, as you can see here. And this is, if these will play, this is a anterior fossa encephalocele, a middle fossa encephalocele, a cholesterol granuloma, the petrous apex. All of these previous required middle fossa approaches, extended approaches, all can be done to a purely endoscopic approach. Likewise, this is a patient with a juvenile angiofibroma. It's here. Capillary hemangioma of the paranasal sinus, hemangioparasitomy, huge paranasal. Again, no need in these cases to do an open approach, can all be done endoscopically. So no question, no one has any controversy about the importance of endoscopic techniques in skull-based surgery. There are, however, controversies in skull-based surgery. We all know these. We all know about the whole issue of cavernous sinus surgery, how aggressive should be, the role of radiotherapy. And one of the most interesting and important controversies are the role of endoscopic techniques in skull-based meningiomas. As you see, there's not a lot of controversy in craniopharyngiomas. There's not a lot of controversy in choroidomas, controversies in giant adenomas. But in meningioma, there's a significant still controversy. So to me, I like controversy. I think controversy in surgery is good. It stimulates discussion. It drives progress. What I do not believe is useful is dogma. And dogma means that you're living in some other people's thinking. So someone who says you must never ever do this way. You must always do it. To me, that is not productive. So what I want to talk today about is what, if any, is the role of endoscopic endonasal approaches in suprasellar meningioma. And those are those who would say, this is a stupid idea, you must never do it. And others will say, well, yes, this can always be done, and others that say sometimes. So why the controversy and what is the truth? What are the answers? Do we have some answers? Well, it's interesting enough, this is not new. This controversy is not new. Harvey Cushing, over 100 years ago, did the first tuberculous cellular meningioma using a subfrontal approach. But even he at that time talked about what is the best method of exposure. And even he suggested instinctively, you must try to take the shortest and safest route. So even at that time, there was a controversy. Now we all know about tuberculous cellular meningioma. These are rare tumors that we have to keep that in mind. We're not talking about common tumors. And they arise, as you know, they're either from the sella, the chiasmatic sulcus, and the limbus. They are surgically challenging, very surgically challenged because of the location. Their close proximity to visual, endocrine, and vascular structures. The presentation, as we all know, mostly is visual, and the surgery is a treatment of choice. The goals of surgery, of course, like any meningioma, you try to achieve a complete removal, but at the same time, minimize brain retraction, avoid manipulation of the critical neurovascular structures. And I want to say here that the goal of surgery should be the same regardless of the approach. So you cannot say, because I'm using this approach and I don't have to do, no, the goal should be the same, and then you pick the approach that will allow you to do achieve these goals. So again, getting back to why the controversy, well, because there's many good open approaches for suprasellar meningiomas. The microsurgical transcranial approaches, the bilateral approaches, we all know, the bilateral subfrontal, the subcranial approaches, the bilateral interhemispheric that I like to use for my open approaches. And then the many, many unilateral approaches from the subfrontal, classical, to the classical pterional, the Asser-Gillian approach, and the supraorbital keyhole approach. So these are many approaches that have been used, and there are advantages of these approaches. We cannot, deny these. These are well-known traditional approaches. You learn these in the residency. You don't need a learning curve. They can deal with all sizes and location of tumor. There's no issues with 3D. We have very well-recognized techniques. There's no issues with CSF leaks, and there's no nasal morbidity. And we have some long-term follow-ups data in these patients. But at the same time, there are disadvantages, and we can't, again, ignore these. These are multiple approaches, so there's not one optimal approach. They're all, it doesn't matter how many craniotomy you make, there's still an element of brain retraction and potential parenchymal injury. There's always a degree of manipulation of neurovascular structures. And there is the most important is the recognized complication rates. And if you look at the open approaches series, even recent series, you see visual worsening up to 30% has been reported. So the question is very simple. Can the endoscopic technique address some of these disadvantages of the open approaches? And if it can't address these, then there's no role for this. Now, what are the advantages of the endoscopic approach? Well, we all know that these are the most direct approach, and going back to Harvey Cushing, it is the most direct approach. If you look at it, of course, it avoids craniotomy, devascularization of the lesion, no brain retraction, and it allows you to better access these deep-seated areas, intercellular, retrochiasmal, and but again, like others, the open approaches are a disadvantage. These approaches that we can't deny. There's the whole issue of lack of binocular vision. These are very technically challenging, doing it through the nose with decreased working space and instrument manipulation. And of course, the whole issue of complication management is an issue, including the whole issue of reconstruction and CSF leaks. While we've made significant progress in these, I cannot say that we have 100% sorted these out. And there is a learning curve. You cannot do one of these cases, having gone to one workshop or seen a thing. These require basically a long-term learning curve. You have to be a good, experienced pituitary surgeon before you can try to attempt these expanded approaches. So the prerequisite for success for me for these tumors is, of course, a very good team, interdisciplinary team, knowledge of anatomy. This is different anatomy from below. We need to do a bimanual, binostril technique. This is, we need to do microsurgical technique. And of course, the whole issue of instrumentation, you can't do these with proper instrumentation. And as I have shown here, there's a training for these and a learning curve, and I would recommend a young neurosurgeon who's interested in these, they should do a fellowship in endoscopic skull-base surgery. So just briefly, the anatomy we're talking about, as you know, the anatomy endoscopic approach to the skull base are the transcribiform, transplanum, transsellar, and transclival. Today, as I said, we're going to look at basically the anatomy of the approach to these suprasellar meningioma, which really what we're talking about is the transsellar and transtubercular transplanum approach. This is what we're looking at, and this is the anatomy that we're looking at. And this is the cadaver anatomy that you see here, the planum, the tuberculum, the sella, periclival carotids, and here's the surgical anatomy at the time of surgery that we do. And again, this is the cadaver looking at the removal. In the end, what we do is do this rhomboid. We do the transplantar approach. Here's the limbus, the transtubercular approach. And we always open the sella in these cases. And in the end, what we're looking at really is the same anatomy, but it's anatomy from above that you can see here, a typical anatomy from above, and here's the same view from below, the same structures, but a different view. So the other thing I want to put in perspective is, the potential role for these. As we know, anterior skull-base meningioma that comprise basically about 25 to 30% of skull-base meningiomas, the anterior skull-base about 9%. If we do away with all of these other, I believe there's no real role. We're really left, as we see here, with a very small amount of tumors that are amenable to this. And if you look at suprasellar, only about 3% of all meningiomas are amenable to this. So we're really looking at very, very small tumors. So what's our series? You can see here meningioma about 46 cases, not a lot. If we can see at least one or two a year or three a year that we do using these approaches. We do a lot more that in fact we do open approaches. So can this 62-year-old patient, headaches, 5 years, this is really not a purely tuberculum, this is more a planum tuberculum. Can this be done endoscopically? And the answer is yes, of course. What we do is basically a craniectomy from below, the way we do it, from above, and then and this is after the removal. And I just quickly go through. Can get a very nice removal of this. And this patient, as you can see here, 5 years after the removal, repaired with a nasal septal flap, no CSF leak, no cognitive deficit, had loss of smell, however. Length of stay only 4 days. What about this patient? This is a physician with this tuberculum sellar meningioma, very classical, presented typically with vision only in the right eye was the only problem with this tuberculum sellar. And these are all the approaches that were, she's a doctor, so she went to many doctors to try to figure out. These were all offered to her. So what is the best approach? Well, for her, she chose the approach. She's a doctor, she had understanding, and she chose, what did she choose? She chose the endoscopic approach. She don't want her brain touched or open, and this is basically the approach we do. As I showed you there, it's really a transsellar, transtubercular, and a bit of a transplantum approach, and I won't bore you with the entire thing, just to show you as you go down. The beauty of these, as you can see, because we've taken the posterior ethmoidal vessels, they can be very avascular, some of these like this, and it's really very satisfying. And then you do the same as you would under the microscope, doing an extra arachnoidal dissection if you can do. And as you can see, if you come here, you see why she had right optic neuropathy, is because this basically involved the optic nerve. And there it is there. Here we come over here. And then you do your dissection is exactly the same as you would be doing under the microscope. You can see it very nicely here. The key is obviously not to touch the optic nerves in any way. And after, very quickly, we get a nice removal of the tumor, and I won't bore you here. And this is to show you the after the removal of the tumor. The repair of these done with a multi-layer intradural at least fascia lata, extradural fascia lata, and then the nasal septal flap that we do. And this patient, as you can see, is 2 months. And you can see basically 7 years with no evidence of disease recurrence. And I'm not going to show you videos, because I think, you can show 100 videos and in the end, it doesn't mean very much. But just to show you here that this is a patient 1 year with this Tuberculosis meningioma. The 4 years that you can see here, this patient is the one I showed you before, is 5 years. This is, here is 6 years. This patient here is 10 years after this tuberculosis meningioma, all these endoscopic. And this is our first patient 12 years ago that we did with no evidence of disease recurrence. But we learn lessons, and the important thing is Dr. Deopujari suggested, when you're doing that, you must learn from your failures, and you must learn and adapt as you go on. And we learned a few lessons. And what are the lessons? Well, this is a 75-year-old patient that I wanted. You know, she's elderly. I wanted to avoid a craniotomy and wanted to do an endoscopic. But you know, vision. Look, she was almost blind, finger counting. But look at the encasement of the anterior cerebral on this side, and shown here. And to me, that is not, as I said from before, you must try to do the same, you know, objective. And to me, to the best, you know, is to try to get a gross total removal. And to me, the endoscopic approach was not going to allow me to do that, and it was dangerous. So this patient, we did basically using my classical. If I can go, there it is. And and then because of this carotid encasement, and so I use this as my classical open interhemispheric transvasal approach. You can see here as we open up the fissure, and here we are. This allows us to spare the olfactory nerves, and this is after the removal, just to show you nicely as we come down, and then after there we bring in the endoscope just to show beautiful view of the sellar area, the carotid arteries, the stalk that was preserved. So this patient, as you can see, 8 years post-op with no evidence of disease recurrence. Also, this patient, 44-year-old patient with this tumor, again, more planum than a true suprasellar, but we learned some lessons. Can this be done endoscopically? The answer is yes, but should it be done? The answer now for us is no. Why? This patient, had normal smell. And we are understanding now, and it took our ENT colleagues to impress on us that olfaction, and maybe as surgeons, neurosurgeons, we're not as, we're a bit carefree about, loss of smell. But loss of smell is a very critical function of patients in terms of it. It decreases their quality of life significantly. And so this patient, we know that an endoscopic approach will 100% in a case like this destroy smell. Now, an open approach, you still have a risk, but it's at least a possibility of sparing it. And this patient I did basically using, again, open, and here we are. As you can see, the olfactory nerve that we were able to spare on one side. We didn't want able to spare the other side. This patient had retained olfaction in this patient. We also learned this. Here's a 37-year-old patient, again, vision. Can this be done endoscopically? And again, the issue is yes, it looks like a small little tumor, but should it be done? We learned that the answer is, for me at least, is no. Why? Because of, first of all, intercanicular invasion, also going lateral to the carotid artery, and carotid encasement. And for me, again, this is not a good case to do an endoscopic approach, and this was done using a right pterioidal craniotomy. You can see here it allows you to get the drill, the clinoid. You cannot do it from below, and ultimately get a nice decompression of that optic nerve that you can see here. And this patient, as you can see, significant improvement in their vision. So again, with the open approaches, and just to show you, these are lesions that go laterally, are not good, that encase the carotid artery, that are, good. And of course, it's huge, large tumor here that we see, with good results from the open approaches. And this is one that is going back again 9 years, 10 years, 15 years with an open approach using an interhemispheric approach. So my come to this conclusion that my indication and favorable characteristics for an endoscopic approach for suprasellar or anterior scolious meningia are basically small lesions, none larger than 3 centimeters, and they have to be midline with very minimal lateral or dural extension and attachment. There should be no vascular encasement, no significant optic canal invasion, particularly laterally. You can deal with an invasion, optic canal invasion medially, like you do an orbital decompression or optic nerve decompression, but not laterally. and there should be, and maybe in elderly patients where the aim of surgery is not only debulking and optic nerve decompression, not the aim is not a total removal, and patients with preoperative loss of smell. The limitations, the unfavorable, are the opposites. These large tumor, vascular encasement, significant canal invasion, and normal olfaction. So the question that I want to ask now is, given the small number, as I said to beginning, 3% or whatever, plus all the limitation and contraindication I've just noted here, some would say, well, is it really worth it for those few? Why don't you just forget about the endoscopic and, you know, and just get on with the open approaches? Because what are the real advantages, you know, with that? Is it less brain retraction? Is it neuropsychological sequelae or better? Is it better visual outcomes, less complication? What are the disadvantages? Do we have some data on this? What about less brain retraction? Well, there's no question that less brain retraction is done with the endoscopic. And this patient, I think the endoscopic approach was useful. She had progressive visual dysfunction, you can see with this meningioma. And the issue here was not to obtain a total removal, but just decompress her optic nerves. And this we were able to do with basically the endoscopic approach. As you can see here, we left some tumor here, but that was not the issue, but decompressed her optic nerves. And this patient did very well. Improvement in her vision, as you can see, no cognitive deficit, was home in 7 days. And I'm not sure any 88-year-old after craniotomy would be able to be home in 1 week. What about the better visual outcomes? Well, as you know, from the literature, they keep talking about the issue that better visual outcomes. Do we have data on this? This is a 50-year-old with left-sided visual disturbance, as shown here. And just to show you here that the open approaches, there's always an element of optic nerve. I don't care how good you are as a microsurgeon, but in the open approaches, particularly with these that are under the chiasm, under the optic nerves, there's always an element of some degree of retraction of the optic nerves that you can see here. And in the end, you know, you can get a good removal as done here, but there always, as I note, an element of and some of these nerves, this looks like a very healthy nerve. Some nerves, as you know, are not very healthy, and any kind of manipulation can cause, you know, postoperative visual disturbance. And this patient did very well. His vision improved, no neurological deficit, but you see, here's the flare changes from the retraction. Now look at that with this patient. This patient also severe visual compromise, with shown here. And here's our here. Look in here. Here's the issue, and here we do not touch the optic nerve. The basically issue, and here's after the removal. You can see the preservation of superior epiphyseal vessels, and look at this nerve, how incredibly vulnerable it was. It almost eroded through by the pressure of the nerve. So any manipulation of this nerve would cause postoperative vision worsening, as we see in some of the cases. So to me, there's no question that the vision, the endoscopic approach has a significant potential benefit in these situations. This patient, as you can see, improved in his vision, 5 years, no evidence of recurrence. Now, if we look in the literature, and these are, you know, a meta-analysis and systemic reviews, again, you see the endoscopic approach appears to have better visual improvement than the microsurgery and less worsening of here. And if you in the literature, there's 100 cases now, papers on trying to compare systemic reviews, meta-analysis, open versus, open versus, open versus. But you have to be careful that many of these are really looking at, are unreliable, first of all, and they're looking at apples and oranges, as we see here, because there's case selection bias. So they lump together olfactory groove, planum, and tuberculum, and you know, these are very, very different pathologies here. And there's significantly bigger numbers in the open approaches, longer follow-up, and the data reporting is not uniform. So they don't look at the size. And most of the open approach, of course, have larger size and smaller size. So let's be very, very careful for the young neurosurgeons to say that when you see these reviews, look at them carefully, because they cannot be, as I said, they can be unreliable. And so this is from Ted Schwartz's group. They trying to look at a similar potential could be done other way. And their series that they published in neurosurgery, as you can see, they also had better visual improvement in the endoscopic approach. And this seems to me very, very strange, but you know, they had significantly worsening in the open approaches. I don't know, this is very high, even for me. So again, what about increased risk of CSF leak? Well, I think the issue here, like anything, when we did our open surgery, when I started 30 years ago, we had high CSF leak rates. But with time, as you can see, it went down. And here with endoscopic approaches now, it's come down to less than 10%. As I said, not entirely solved, but definitely better. And finally, incomplete tumor removal and increased recurrences. Does it cause, is this a disadvantage? Because some people would suggest that you can't get as good a removal. And so if you look at, this is a series, again, be careful about systemic reviews, but this showed about approximately for Tuberculous meningiomas about the same, no significant difference in gross total removal. This is a series that we did that I had. In fact, this is Kiki Terrell's son that did a fellowship with me looking at this Tuberculous meningioma systemic review. Again, a little bit higher gross total removal rates in the open approaches than the endoscopic, shown here. And this again, Ted Schwartz's showing really no significant change between open and endoscopic. And I think people more are coming with this, that you know that there isn't a lot of difference again, gross total removal rates. This is our series now that was alluded to by Dr. Deopujari. We published this 10-year experiences. We wanted to look, you know, ahead long-term to see. So we had basically 52 patients. You see tuberculosella was 13 open, 20 endoscopic. Our gross total removal rates, as you can see, were really not significant, shown here, slightly higher in the open. And the importance of tumor recurrence, while again slightly higher in the endoscopic, was not statistically significant. So have I answered the question? Anterior skull-base meningioma, is there any role for the endoscopic approach? Well, I think, you know, we need a randomized trial, right? But there'll never be a randomized trial. We all know no one is going to do that. So what we can look at now is consensus statements and guidelines. And this brings us to the international, first international consensus statement on endoscopic surgery that was published last year. We were asked to be involved in this, and they looked at basically databases with level of evidence, grade of research, and then grade of recommendation. And we were asked to do a olfactory group, but the tuberculum plenum were the same findings, basically. And these were the findings of this, that the case selection bias and non-independent reference standards and no sensitivity analysis limits any real accurate attempt to compare transcranial endoscopic approaches. However, with careful patient selection, the endoscopic approach can result in equivalent gross total removal rates as open approaches with overall probably better visual outcomes. While CSF leak remains higher with improved reconstructive techniques, including nasoseptal flaps, the rates are approaching acceptable levels. And the feeling is that the endoscopic approach may become a preferred surgical approach for a select, and I want to emphasize that, a select population of smaller midline lesions. So this is, of course, the famous curve that describes basically Scott's parabola, described a surgical procedure that had a lot of promise, but in the end it falls off the cliff because it really is not. So is the endoscopic approach for tuberculous meningioma going to do that? I don't think so. I think we're at this stage, we're here. We're trying to, again, develop very careful guidelines to select careful patients that will benefit from this particular approach. So in conclusion, in the absence of any high quality evidence in the literature and unlikelihood of randomized trial, we have to analyze larger prospective series with longer follow-up to try to validate the efficacy of endoscopic approach, particularly in terms of gross total removal rates, complication rates, and incidence of recovery. I believe that the traditional open surgical techniques remain the gold standard and the approach of choice for the majority of neurosurgeons for the majority of skull-base meningiomas. The endoscopic approach will likely remain restricted to those skull-base units known for their expertise. You have to have expertise in these who recognize the limitations with respect to tumor morphology and advantages to visual function in selected cases. And neurosurgeons caring for patients with anterior skull-base meningioma should be prepared to offer the patient an approach based on current available evidence, the neuroanatomical features of the tumor, patient input, and the surgeon's own experience. And again, I cannot sing here. If you're not experiencing these, then you shouldn't be doing these. So, this is for the panel, Chandra. This is a 64-year-old patient, decreased vision, acuity. What is the best approach? What would they use? Okay, I'll ask them later, and then you can see. What did I use?
Let us put the question to Dr. Nair and Dr. Sankhala. Both of them are doing these surgeries, so let's see what they have to say.
Yeah, what do you have to say?
I think there's a good case for an endoscopic approach.
Okay.
What do you feel?
The only thing is I'd like to just see how much of the optic canal is involved. It looks like the involvement is from the medial side. If there is involvement in the lateral side, I wouldn't choose the endoscopic approach. But if the involvement is on the medial side, I think there's a good case for an endoscopic approach.
Good question. So both would do an endoscopic?
Yes, I would also
Okay.
think about it. Except that I'll see more carefully the posterior part of the tumor and the vessel relationship with the capsule.
Well, I think this is very important, what they're saying, because the issue is careful preoperative assessments of these must be done in terms of imaging. And some people, we will do also fiesta sequencing to look at the issue of the vessel and so forth. And we did that. I didn't show all the mimi here. We did not feel there was any significant optic canal invasion. We did not feel there was any vessel vascular. So again, exactly, we did this endoscopically. And very just briefly to show you, here's the removal of the tumor.
In your protocol, Fred, do you always do a CT with CT angio? That's what we do before we decide on an endoscopic.
Yeah, we do a CT. Yes, we do a CT. Not necessarily a CT angiogram, but we'll get a CT. Our ENT surgeons, as you know, they love CTs. They don't do MRIs. I don't know. They do MRIs because of the anatomy and so forth. So we always do a CT.
Correct.
So here it is. Here's a beautiful view of the removal of this tumor. 4 hours, vision improved, no CSF leak, length of stay 4 days, CSF at least 6 months post-op MRI. So the evolution of skull-base surgery, quo vadis, open versus, I think we are beyond this now. It's a very good for young neurosurgeons to see people, conflict and so forth, but I think we were beyond that, and we were really looking at the issue of open and minimally invasive endoscopic. And with that, I think for young neurosurgeons, there's a bright future for skull-base surgery. Thank you for your attention.
Thank you.
Thanks, Fred. I think meningioma's lecture and the general topic gives us a very good indication why you need to know the principles of skull-base surgery. I mean, endoscopic technique is extremely important, and the person who takes the decision should probably, like Fred has done, should be equally conversant with open skull-base surgery before we make this decision as to should we be doing this endoscopic or transcranial. And I think that's a very important aspect. And probably is not given as much importance as it should be given. And, Kasam and colleagues described the grades of endoscopic skull-base surgery at some stage. And I think that still holds true. So I would start with the basic question of how important do you think is the cadaveric and the lab training? Sukhdeep Jhawar can tell us, and I'm sure Domenico would have something to say. Sukhdeep comes from an institution. He is Atul's student. So you all know Atul. He is not in favor of endoscopic surgery, and his institute does not follow that. And Sukhbir from there went to Pittsburgh to learn endoscopic skull-base surgery. So I want to know his experience, how different he found it, and has it made an impact on him? Dr. Jhawar. Can you hear me?
Sukhdeep, are you there? Unmute yourself.
Yeah, thank you, sir. Thank you. And very nice talk and highly educative, lot of learning. And I congratulate all the speakers for such a wonderful and very basic for young neurosurgeons. As sir told, in our department, endoscope was something of a stigma and it was not a very popular instrument. But then with all the technology and everything, when I have special interest in anatomy, and when I attended one workshop here in India for a endoscopic skull base, and in the workshop you just get a idea, and I was very confused about the anatomy. Where is the ICA? Because in the traditional microscopic approaches we hardly saw internal carotid or all this anatomy. So I decided spend some time in the lab and did lot of dissection, and I think we know as a neurosurgeon that anatomy is our basic thing, because without anatomy you can't do these approaches. And learning this anatomy from below is like you have to unlearn few things and learn from a different perspective. Anatomy is same, but your perspective changes. Things look different. It's a cylindrical view, and 3D depth perception, all you learn when you work on the cadaver. And it really helps once you start operating these cases. And I think Professor Dominic will also agree with me and will give his inputs in this. Thank you.
How much do you think, Domenico, your lab work helped you? And you have also developed newer approaches with that. So you should be able to tell us a little more on this.
Yeah, of course. Thanks a lot, and thanks, Sandeep. I guess that the lab, aside from the approach, it is fundamental, because as long as you start working with a new thing, like a new approach, a new argument or topic or whatever, you have to train and train again. Like, to be honest, like, we still believe that the anatomy is fundamental, because it is not anymore like a conflict as Dr. Gentili showed us. It is not that if you go microscopic, transcranial, or if you go endoscopic, you will win a special battle. You have to learn to deal properly with something, with the anatomical region, and the anatomical region usually are full of important structures. Once you have learned what is in that particular area, then you can start imagine how you deal with that if something it is distorted. My experience, my personal experience, it is this one. Like, I do not do, I say, like, once in a while I do vertebral surgery, like spinal discs, and I help like some other surgeon at my institution. If I have to do that case, then I only refer to anatomy. Probably I'm not experienced, I'm not that fast as other colleagues that manage properly that pathology. But for sure, I can tell you that as far as I start, I only remind to me like it is anatomy, and you have to recall your anatomy while working. So it is fundamental, like really, really fundamental. And one thing that also today it is fundamental, it is like reconstruction with every kind of software that is online today. Like, if you start having maybe you have not yet confidence with the instruments, and you do not have specimens to dissect on, maybe what you can do like is reconstruct three-dimensional view with software, with CT, with MRI, whatever it comes of your knowledge. It is beautiful, because I mean, like, every one of us like is indebted to Professor Roton that made that beautiful anatomy, like that show it. But still, it is on a book like any other book. It is not like that is not important, but when you feel and you get confidence with tiny spaces, then you enlarge your horizon, and maybe you can shift in between a choice that is personal and school opinion, because everyone, I'm very happy to say that we share this opinion in my institution.
Thanks, Domenico. I think I'm going to put a combination of question to all the panelists, starting with you. What are your current indications to do an extended approach for a pituitary tumor? And what is your current indication to do transcranial surgery in a pituitary tumor?
Probably there are three magic words: internal carotid artery, lateral extension, basically. Sometimes, like, our concern, it is the lateral extension. Most
For
of
the
you
transcranial approach, you mean? For
yeah,
the cranial approach.
I mean, the line in between, it is the lateral, like the first one that I can tell you, it is the carotid artery. If a tumor, although it is soft, passes the carotid artery, no way, you cannot go via the nose. Because
what do you think, Professor Pathak?
Well, I think if it is just impinging on the cavernous sinus area, that's fine. But if it goes beyond that, of course, there is a question that whether you should really violate that. But at the same time, of course, if we feel that the dissection can harm the anatomy and transgress certain important structures, we will then be forced to sort of decide whether we leave a little bit of tumor behind rather than try to be too much violent about it.
So basically 360 degrees, I think invasion of the cavernous sinus and the tumor lateral to the carotid probably are indications for transcranial surgery. Dr. Nair, you have to unmute yourself.
The first thing is about, I think Domenico hit the nail on its head when he spoke about tumors that go beyond the diaphragm. And I think this is an unrecognized entity. I don't think literature speaks about it enough. Most of us talk about pituitary tumors as, extraarachnoidal tumors which readily come down when they're approached to the sella. And one reason why we get a lot of apoplexy and residual tumors after surgery is because we do not recognize these tumors that go beyond the diaphragm. The extended approach gives us a very panoramic view of the suprasellar space and the visualization of the suprasellar system. And it also lies along the long axis of the tumor. So it makes it possible for us to follow the tumor from the cellar into the suprasellar system and then even into the third ventricle. So we've been working on a small series of patients where the entire third ventricle was involved and could be approached through one axis. But tumors that go beyond the internal carotid artery into the sylvian fissure are very poor candidates for the endoscopic approach. They might probably be done in two stages where half of it is done from the transcranial route, and then the residual is taken out from the transsphenoidal route. Regarding tumors that go into the cavernous sinus, I think with the recent papers published by Dr. Miranda now, we have a very good indication of how the carotid artery divides the cavernous sinus into compartments. And by exposing the carotid artery at the level of the lacerum onto the paraclinoid carotid, the medial compartment, the anterior and the inferior compartments are very readily tackled. But when we have tumors extending into the lateral compartment, where we have the third, the fourth, and the sixth nerves, which are not covered by arachnoid, then there is an unacceptable risk of giving the patient extraocular palsy. And when the primary indication for surgery itself is visual recovery, extraocular palsy in that setting is devastating, because either do you give an improvement, you also give a dead eye, which the patient can't use. So cavernous sinus involvement per se in the medial, the inferior and the posterior compartments can be approached endoscopically. The cavernous sinus the ICA can be well exposed, the dura can be opened up to the wall or even beyond the anterior surface of the ICA, and tumors can be decompressed. And if they're soft tumors, they become very amenable to surgery, but even relatively fibrotic tumors can be resected. But tumors that go into the lateral compartment of the cavernous sinus are probably best left for follow-up or for radiosurgery.
Fred and Professor Locatelli, your comments, please.
Chandra, this is for pituitary tumors you're talking about. Right?
Yes, only for pituitary tumors.
Right. So, pituitary tumors, we've published on giant adenomas, as you know, about 6 or 7 years ago. And it's interesting, we did not use the expanded all that much, so the need for an expanded and even giant pituitary tumor is not that often. And I think to me it would be one that goes a little bit more anterior, you know, that into the planum and so forth, then we would use an expanded approach. I am not a keen fan of cavernous sinus surgery. You know, there's still serious. So to me, for sure, I would agree with Domenico or the others said lateral to the carotid, never. I think it's crazy. For functioning tumor, you never get a control, a remission. And so maybe the medial cavernous sinus, yes, because the tumor leads you to that. So you just follow it to the medial wall, but never to the lateral wall. So I would not do that. And then, of course, those that are, as was also mentioned, really significant lateral extension, you know, middle fossa, you have to do it from above. But I don't think we did one, interesting, in our series, I don't think we did one, although the series was on endoscopic approaches, we did an open approach for, for a giant adenoma.
David, would you like to comment on this?
Well, I agree with Fred regarding the difficulties. Difficult to indicate a transcranial approach for adenoma, but I think that we normally for adenomas, just for pituitary adenoma, we can go transpterygoidal to the lateral portion of the cavernous sinus, because me and Paolo Castelnuovo and Giorgio Frank and Diego Mazzatenta and Pasquini, all the group, in Italian group, we started with this operation a long time ago, and we still think it's useful to go there to empty obviously you can use, you are not going for a complete resection, but you can decompress. You can decompress and you can have a good result, and after that you can irradiate, and the risks are very low if you know what to do. On the other side, I would never go for a meningioma or for something else in the cavernous sinus. That's my opinion, but it is another topic. The topic about giant adenoma is mainly related to the approach to the normal endocellular and suprasellar approach, sometimes extended, and normally if it is too lateral, we go for a combined or for another approach. If it is lateral, very lateral and solid, that's it.
Dr. Banerjee had joined us. Are you there, Deepu?
Yeah.
You keep on talking about some paper which talks about the delineation of cavernous sinus component of the tumor much better with the enhanced scan, and the possibility of going into the cavernous sinus depends on that. Would you elaborate on that?
Yeah, this was basically an article from a Korean group which analyzed radiologically, and they found that when we do a dynamic scan, early part like the stalk enhances, and then the cavernous sinus enhances even before the pituitary gland takes the contrast. So he found that there is, even if there is a carotid artery is compressed by invasion or indentation of the tumor, the rim around the carotid artery, there is an enhancement. So he called it as a periarterial enhancement. Now he said that even if it is moved or the tumor is engulfing, say about 270 degree, but if this periarterial enhancement is seen on an early scan, dynamic scan, then it means that it is indenting, it is not invading. But if more than 45% of that circumference of that periarterial enhancement is not seen, then they found significant statistical involvement in the carotid artery. So I found that article quite convincing, and I do ask our radiologists to do that, to report that that angle also. Apart from, of course, knobs, lines and other thing. So that is one thing I thought was very, very useful.
I would end this round of questions with Dr. Sankhala. He has written, or he's writing about extended approach for pituitary tumors. So Suresh, can you tell us what are your indications for extended approach for pituitary tumors, please?
Most of our tumors are extended in the subfrontal region or suprasellar region. My opinion about the laterally extending tumor will remain the same essentially. I don't go too aggressive in the cavernous sinus. As Fred said, if it is just indenting or invading the medial part of the cavernous sinus, that is fair enough, because then it is in the continuity and the tumor will lead you there. But most of the tumors which are extending laterally or far lateral than that, probably I would leave it alone and not go for the extended approaches.
Thanks. I think one of the most important things, which I just commented at the end of Domenico's talk, and I would like to take it up now for people's opinion, is, you know, in large tumors, when you cannot take the tumor out either because of the vascularity or because of the consistency or whatever problems you may have, when do you decide you can leave the tumor behind? Because one of the major problems about the postoperative pituitary necrosis or tumor necrosis depends on how much tumor you left behind. Would you throw some more light on that, Domenico?
Yes. There is this risk. There is this tremendous risk because when you go above in the suprasellar supradiaphragmatic space and you leave like more than 5%, probably there is the high risk of have an hemorrhage inside the tumor that, of course, it has been left behind, and then you will have like a severe consequences because you will have brain edema, you can have like also vasospasm, and you can have like the worst that you can expect. Of course, this can happen also when you're dealing with the intrasuprasellar subdiaphragmatic tumor. We had once a case of an old lady with a recurrent tumor, and we just had like pressure by our anesthesiologists like to speed up the procedure. So we supposed to see the diaphragm come into view, and we missed like a piece of tumor that remained like clogged in between the diaphragm and the dura, the anterior part of the dura, and the lady lost the vision completely. We entered again the surgery the morning after, but no chance of recovering. So and we found like, of course, like an ischemic hemorrhagic tumor that side. If we admit that there were the tumor that we are leaving behind by the prevision at the MRI, it is superior to that rate of 5%. Let's say we will not go via endoscopic endonasal, or at least, as Davide said, like we will have a combined approach, because it is not safe at all. Like hemorrhage, like like a apoplexy, if it stays there, it's okay. But if there is neurological consequences, hydrocephalus, maybe, and of course, like you leave the hospital at night, and at night maybe the things go slightly subsiding, and you will have like 8 hours at least of not checking on the patient, and that is very bad, very bad.
I think a very
I think there's an article on post-operative apoplexy in pituitary tumors by Mahapatra from All India Institute, where it shows that residual tumor can bleed and produce devastating effects. So that's very important if you leave behind.
So what is your criteria, Ashish? When do you decide that you can leave behind the tumor?
Well, I mean, first of all, I decide whether I can remove the tumor at all or not. And in this respect, I was just very much prompted to ask about a situation which I have sort of faced twice. There are invasive destructive pituitary tumors, which I've got 2 cases where the skull base was invaded. They're not, histologically, they're benign, but they have destroyed the bone. And this was an 18-year-old boy who came with a piece of tumor when he sneezed, and it was, the whole skull was destroyed. It turned out to be pituitary tumor when we were thinking of something else. And these lesions, sometimes people even talk of giving chemotherapy because we cannot remove whole of them. So I don't know what's the experience.
Most of these lesions, I think, are prolactinomas.
No, they were not. They were, these 2 cases are not. Yes, yeah. What you're saying is right. Invasive, extensively growing tumors are prolactinomas. We thought that they are prolactinomas, but they didn't turn out. And even in the British Pituitary Association, I can't remember the full name of the association, where we were discussing, they were also thinking of giving chemotherapy in these patients, because radiotherapy also becomes a difficult option in these cases. Even though they're benign, they are very much extensive. So
Temozolomide has shown some
Yeah,
benefit,
yeah.
but
So they talked of temozolomide, but nobody was sure about it. So
the other problem with these kind of patients, especially prolactinoma, invasive prolactinomas, is that you give them cabergoline, the tumor shrinks nicely, but then the patients present with CSF leaks. We have about 3 patients we had to operate for CSF leak after treating them successfully with cabergoline. Anyone would like to comment on that experience?
So Chandra, just a comment. Yeah, that happens. We are aware of that, and that we've all had experience with that. Not that often, but can happen. Going back to the issue, I agree with everyone. The issue with regard to giant adenomas, that if you do not get a complete removal, that there is a risk of postoperative hemorrhage. But let me say that you can also get hemorrhage or blood with a giant adenoma. So you have a big space, and you see at surgery, everything is fine. They come down, you see the diaphragma, you say, a beautiful thing. Postoperative CT, blood in that area. Not to be worried about that. That is blood because there's a big hole, and as the patient wakes up, he hyperventilates, the space goes there, and something had to take space of where that tumor was. Those are not of concern. The patient, usually the vision is okay. They don't have any vision issues, and you just watch, repeat in 4 weeks, you'll see that blood is all gone. So not all hemorrhages or blood immediate postoperatively is serious, and you have to rush in back. You chunk the patient is stable, that blood will observe. But I agree that if you leave a large part, then these hemorrhages can be very serious, and you can have vision loss, and we've had to go back in those situations.
So if it is asymptomatic, not to worry too much about it.
Yeah.
In one case of 4 centimeters tumor, there was a large clot. The patient was conscious that the hydrocephalus developing, and headaches due to hydrocephalus. We just treated the hydrocephalus, and the rest of the blood gradually went away.
It's a lucky escape kind of a thing, but
escape,
it is a real problem. And basically, there is very little to predict it except for removing as much tumor as you can. I think that's the main issue. I would now move on to craniophryngiomas, and my first question, Dr. Locatelli told us that there are many cases, especially if the patient already is hormonally affected. If there is a pituitary insufficiency, he doesn't bother too much about the stalk. Is that would everybody agree with that, Fred, Dominic?
Well, let me say.
Sorry, did I say something wrong?
Well, I did not exactly say that there is some pituitary insufficiency. It's enough to resect the stalk. Resect the stalk is mainly an anatomical consideration. If you have the tumor clearly located from the beginning inside the stalk, obviously you have a complete pituitary insufficiency. It's logical to resect the stalk if the patient is older than is no more a boy, because you preserve the possibility of having a recurrence. I am always trying to save the stalk. When I see that the stalk is not, if I leave a clear remnant in the stalk, or I see that the stalk is divided in many subtle strings, it's useless to leave the stalk because to show you are a good surgeon. Because in the next year you have to take the stalk and to go back again. That's my idea. Okay.
Sorry if I misinterpreted, but do you have any different idea on this, Fred?
Yes, I do. You saw, if you've seen my presentation, you see I have this really issue about the stalk. I have this belief that craniopharyngiomas generally arise from the stalk. They're Rathke's, pouch and whatever. So I've done, and before I had endoscopy, I did not believe you could remove a craniopharyngioma totally and spare the stalk. Okay, total removal and spare the stalk. And that was, the open approach. Then when endoscopy came in, I said, I could see the stalk. I said, now we can, maybe spare the stalk. And I can show you beautiful videos of me sparing that stalk. But follow that patient. 3, 4, 5 years recurrence at that stalk, okay? The problem is that yes, you can spare the stalk, but you're leaving cells in the stalk and they will recur. 4 years, 5 years. So for craniopharyngioma, a 2-year follow-up, 4-year follow-up is nothing. Like a meningioma, 2, 4, 5 means nothing in terms of recurrence. You got to follow them 5 years, 10 years. And with the stalk, Davide, is what I found that you have a beautiful looking at the end, but 4 years later, you see the recurrence there. So what I do now is very simple, particularly with people who have normal pituitary function, because to destroy pituitary function, like I told you about olfaction, is an incredible thing. And you talk to your endocrinologist, they say, oh, you know, we can give replacement. No, they'll give all the replacement, but it's not the same as you giving your own hormones. They, you know, significant decreased quality of life. They never fully, how do you say, replace well and so forth. So I give the patient an option. You know, an intelligent patient who can say, I say, listen, I can go in, I'm going to go in, and it looks like I can get likely a total removal, but the likelihood is you're going to have to take your stalk to get a total removal, and then you'll never have a recurrence, but you're going to be on pills, thyroid, DDAVP, whatever. Or I can, you know, do a nice radical removal, deal with the vision problem that you have, but I'm going to likely leave something, and there's a chance for recurrence. What do you want? And it's curious, you see some people absolutely take the stalk. I don't care. I don't want anything left. You know, whatever. And that, to me, that's simple. Good, bang, take the stalk and do it. But others, no. When they understand that, they say no. And but then, of course, I tell them that, you know, there are other options. Radiation, we know radiation. We can't ignore radiation. As much as some of us don't like radiation, radiation in craniopharyngioma have a very high control rates, 80 or 90% at 10 years controlling it, and in older, you know, people. So they know about that. They say, no, I'm happy. You know, if it's going to come back, you say there's another treatment or whatever. I don't want to take the pills. So that tells me fine. I don't have to do it. So in many cases with a patient, I let the patient make the decision, and it's easy for me when I go into surgery. But I do not believe, with rare exception, as I said, you know, I never say always, never say never. But the likelihood of getting a total removal of craniopharyngioma and sparing all pituitary function and never have a recurrence, I think is very, very unlikely.
Domenico, do you think the CASAM classification about the location of infundibulum in relation to the craniopharyngioma has helped us in making these decisions?
Yes, I think so. To be honest, like it helped like in dissection and classification, but standing from an anatomical point of view, I totally agree with Dr. Gentili. Most of the craniopharyngiomas that we deal with are involving in a certain percentage the stalk. I don't know if there's the origin of if they enter from the sella or from whatever, but the stalk is always affected. Our position is just in between, like, because we saw a lot of cases like that had progression after we transected the stalk and coagulated the stalk, but we have also some cases of hypopit after not touching the stalk. So our policy is just to have radiotherapy as much as possible after having like adapt. Did I leave something behind? Yes, so please refer to radiotherapists before it's too late. And also, we rely on a close monitoring of the endocrinologists, not in terms of MRI, but in terms of functioning. So we had like in the last 5 years, a lot of people that get lot of weight immediately after surgery. Although, like the first MRI after 1 week can be clean, we do prefer have like MRI, because there is something that is, we are not yet understanding. So there is something of craniopharyngioma pathology that's still going on in the stalk or in the hypothalamus. We are not that wise as Dr. Gentili, like to leave the patient. Sometimes we are really bad with the patient and we push the patient to receive radiotherapy, especially if they are over 50 or over 60. And we are also going back, like we had like a 10% of patients that are like pediatric patients. We are also like pushing the PET team or considering the radiotherapy before like the child has reached like his goals, because otherwise I totally agree in this part of the, you will have recurrence for sure. Also Davide said, like also the Professor Locatelli said, that if you leave something behind, like 1 year later you have to go back again and cut that part. So
if I may say some words again.
Yes,
I was provocative because I know that when someone resects the stalk, always they say, hey, it's not a good surgeon, he goes for the easy way. It's not true. The idea is, as I showed before, 15 years ago, always spare the stalk. 5 years ago, always spare the stalk. If now I accept the idea that if the stalk cannot be spared by anatomical and by visual consideration, I tailor and I decide to resect. But not if the stalk is functioning, obviously. It's different idea, because most of us, when we try to dissect the stalk, we fracture, we damage the hypothalamus, and at the end we have a stalk like a subtle string, but not working. And it's worse than resecting. So my idea is always spare, but if you see the stalk is not spareable, resect before trying to save at any cost. That's my idea. I don't want to say I am different from the others, okay? That's clear. Because
no, I think you have made yourself very clear, Davide, and we appreciate that. Suresh, you have written about retrochiasmal craniopharyngiomas. How do you recognize that particular entity, and why do you think endonasal works better in that particular variety?
You recognize those tumors very well on the MRI scan, preoperative imaging, and if you look carefully, you will really find that the optic chiasm is even prefixed also. And most of the times, these tumors in older days, when we used to approach these lesions through the craniotomy, we used to really go through the lamina terminalis, and even then it used to be a little difficult task to really remove it completely and to separate it from the pituitary stalk. From that point of view, I think the endoscopic endonasal approach is much better, because then you approach that area directly and it's straight in the line of your dissection. And that is why probably you achieve the goals, the surgical goals, more easily than the upper craniotomy approaches.
Thanks, Prakash. I think Ted Schwartz has written a book on endoscopic skull-base surgery in children recently, and I'm sure you must have seen quite a few cases or helped him with that. So what do you think is different in terms of thinking about endonasal approach in children for craniopharyngioma?
So the first thing is, I think in our own Indian scenario, so I think nearly 70% of our patients tend to be pediatric craniopharyngiomas. And one big subset of presentation is pituitary deficiency. So 25% of our patients in my own series presented with growth deficiency, short stature, or amenorrhea, primary amenorrhea. And so they're already hypopituitary.
Can you speak a little louder?
I'm sorry.
Get the mic a little closer.
So at presentation, nearly 70% of these patients tend to have hypopituitarism. A second lot of my set of patients are recurrent tumors who also had hypopituitarism after their primary surgery. So the attempt or the possibility of preserving the stalk itself remains less. but if possible, it should be preserved. We should always go back to the paper by Yang and Parsa published in 2010, which shows outcomes between subtotal dissection and radiation to be equivalent to gross total dissection, both in terms of long-term survival and in terms of quality of life. And that is a very important thing that we need to look at when we are treating children. The overall quality of life, because even at the end of 5 years from surgery, these children, maybe a 5-year-old child, 5 years after surgery is just 10. He still probably has not attained puberty, and he still probably has not been able to achieve these growth spurts. So that brings us to the second problem, and that is the ability to treat these patients with growth hormone therapy in the presence of residual tumors. Now, it has been recommended by the Endocrine Society that you can treat them with growth hormone therapy in the presence of residual tumors. However, it's a great cause of concern for the endocrinologists who are treating them, because you're always at tenterhooks as to whether these tumors will progress after treatment with growth hormone therapy. The third important thing is that I think this is also under-recognized, and that is the essential behavior of different components of the craniopharyngiomas to radiation. So craniopharyngiomas tend to be solid, cystic, or calcified. And calcified tumors very rarely tend to respond to radiation. In fact, one reason why these patients come back with multiple recurrences is because they have calcific residue which was not removed during primary surgery. In fact, the thin cystic wall often responds much better to radiation, and that is why a lot of these patients tend to do well after Ommaya placement and radiation when they come with thin suprasellar tumors that are dealt with by minimally invasive techniques like an Ommaya placement. So I think when we will decide to treat them with gross total resection, resection of stalk, and when we will decide to treat them with subtotal resection should be based upon all these criteria. However, I do remember that Dr. Schwartz always used to say that he would prefer to cut the stalk if he knew that he would be able to get a gross total resection.
You are probably aware that in 80s, Raimondi, one of the pediatric neurosurgeons in Chicago earlier and later in Italy, along with another pediatric neurosurgeon called Rogeri, in 80s has published a very important paper that cutting the stalk may not always cause a permanent diabetes insipidus. And in fact, they encourage that if you require to do it, if you can otherwise get a radical excision. I mean, if the stalk was the only, I mean, if you are really talking of the transinfundibular variety, let us say, it may be probably better off that to cut the stalk because the portal system can reform and you can still get a complete recovery from so that's another point of view, but I think you have put some important points.
One additional thing that the endoscopic corridor gives is this view of the third ventricle, which is unparalleled. So I think when you approach the same tumor from the transcranial route and when you leave a residue, you're not actually sure of whether it was inseparable from the brain's hypothalamus or whether it was just because you could not see it. On the other hand, when you approach this from the endonasal route and when you leave a residue, you know for sure that you could not take it. When you approach this from the endonasal corridor, and when you leave a residue at the wall of the third ventricle on the hypothalamus, you know for a fact that this tumor will not be accessible for a second surgical procedure. And the incidences of hypothalamic obesity are much less with endoscopic endonasal approach, probably because we're able to appreciate the wall that way.
This is our experience as well. And I would like to ask last question on craniopharyngioma to Dr. Jhawar. Is he still with us?
Yes, sir.
Sukhdeep.
Yes, sir. Okay.
Sukhdeep, do you think when we are doing the endonasal dissection, do you find that it is much harder to do it in children, and what is the cutoff age do you think you can safely do transnasal surgery for children?
Yes, of course. In children, it is more difficult being smaller this area and the instruments. And for personally, I'm not much experienced for transnasal for craniopharyngioma. I prefer the transcranial approach, and it's been giving me reasonably good results. Another thing is, especially in Indian setup, we have to see patient, they don't do well with hormone replacement, and sometimes they'll end up with many issues. So preserving the stalk is, I think, for me, it has been a better option than keep a close follow-up, and if there is recurrence, then maybe.
So we have the whole 360 degrees perspective on this issue now. I think I appreciate your comment. Suresh has something to say,
Yeah,
and then we'll move on to meningiomas.
Yeah, just the last question to David. We have not talked about the calcifications that is frequently associated with the craniopharyngiomas. And at time it is so firmly adherent to the structures, particularly the vessels or perforating vessels or hypothalamus, pituitary stalk and all that. So according to you, how far we should go to really change this calcification?
Well, I am not chasing calcification for itself, because if a calcification is inside a vessel or inside a optic nerve, I leave it. Obviously, if the tumor is most of all is calcified, as I shown in my videos, well, you have to take the tumor together with calcification. So you have to disrupt the calcification to take it out. But I leave calcification when they are in danger positions, for sure. Thanks.
Yeah. Thanks. Thank you.
We have
Anybody
a question from the audience before we go to meningiomas. It is for a general endonasal surgery. How frequently you use navigation and how frequently you use vascular Doppler? Anybody can answer.
Always.
Always, always.
I think all extended procedures you need navigation as well as Doppler.
Yes.
So let's move on to meningiomas. I have two.
Can I just add one point? I've got 6 patients of craniopharyngiomas, large ones, who are surviving more than 20 years. And I believe I've left behind a little bit. So I believe that craniopharyngiomas are a heterogeneous group. And one of them is surviving for 35 years now. And he still doesn't show anything more than a small speck, which I believe is the portion I left behind. And without any radiotherapy, anything like that. So there are patients who have been operated, and I usually choose the translaminar route in these cases, which gives me very good view actually. And I use the endoscope to sort of see that I've removed everything. Or
transcranial endoscopic.
Endoscopy using translaminar terminalis route, because the laminar terminal is very easily stretched and you can just open it and the tumor is right in front of you. And then you can use the endoscope at the end and take out everything. So that's what helps me a lot, and it gives good result.
Now it becomes 360 degrees perspective.
Yeah, because my pendulum has swung from hearing Harold Hoffman, who would say, I will peel the tumor off.
Yeah.
And then when I went to work in the NHS UK, they were extremely conservative. They would just do a little bit and then hand it over to the endocrinologist or radiotherapist. So I've seen both aspects of it.
Chandra, that's a good point, because I don't know if it was Domenico or someone with regard to the timing of radiation.
Yes.
I do not do it immediately, because exactly as Suresh said, there are those, for whatever reason, that's why we do not know yet, the molecular, we still have to do some more molecular studies to turn out why this meningioma, we know, papillary and adenomas, but why a certain meningioma will recur 100 times that you've done, and this other one, like him, after 40 years. So I do not immediately, if I have left something, will go radiation. Follow very quickly, but at the very first sign that the thing is coming, then I will radiate. Now, there's a downside to that, because occasionally you get this cystic that will come up in 6 months, and then you have to go back and drain. But I will do that rather than treat everybody with radiation where I know that there'll be a certain percentage that will never need it. So I wait for the radiation.
Our policy and our radiologists, radiotherapists agree with it, is that in children, we wait for second surgery before we give radiation. While in adults, I'm ready to, I'm very happy to refer them for radiotherapy immediately after the first surgery.
Not necessary.
I mean, anybody above 50. So going on after meningiomas, I think your last slide I would take from there. What are the current indications? And you put it very nicely that there is probably a small subset of tumors which are in the midline, which are very, very good for endonasal surgery. Now, do you think how much importance the presence of olfaction plays there when you decide this?
Yeah, so olfaction is more anterior, like, olfactory groove and large planum, you're going to destroy olfaction. Tuberculum sella, posteriorly, you spare olfaction. You can spare olfaction. And for those, olfaction is still very important, but it's not as an issue from where the more anterior ones where you're going to destroy smell.
So if you have a planum tumor and the patient has preserved olfaction, would you favor doing a transcranial approach?
Because of the olfaction, now I'm in the situation where attacking to the patient, looking at the size, and we didn't talk a lot, but that's so important. The size of the tumor is important. The location of where it is. I will make that decision based on those criteria.
Dr. Schwartz and Dr. Prevedelo make a big point about using 30-degree scopes to avoid this loss of olfaction. Dr. Nair, do you have any opinion?
They do use, Dr. Schwartz uses a fixed, he uses an endoscope holder. Dr. Schwartz uses an endoscope holder. And for the more anteriorly located tumors, he uses a 30-degree scope for locating the anterior part of the cranial fossa. But there's a paper that Dr. Schwartz had written and was published in Neurosurgery Focus in 2017. I was also lucky to be part of the published author list. And there we looked at the extent anterior to the point where the sphenoid sinus joins the anterior skull base. We looked at the presence of involvement of olfaction, and we looked at the presence of extension lateral to the optic nerve and the carotid artery. So for patients who had small tumors which were essentially either beneath the chiasm or just anterior to that, with preserved olfaction, and with preserved olfaction, the endoscopic approach gave very good outcomes as far as visual group was concerned. However, for more anterior tumors, located more than 50% of their volume anterior to this line between the planum and the olfactory group, the approach preferred was the transcranial approach because it gave the surgeon an option to preserve olfaction and also limited the amount of dissection that he had to do against the brain. So these were broad indicators that could be used.
Domenico, what is your policy?
To be honest, like nowadays, meningiomas, we are just leaving to the transcranial approach. We keep on performing endoscopic endonasal for tiny tuberculum that eventually may invade the medial aspect of the optic canals. The classification that Dr. Nair told about the anterior extension also is very important for us, because if also like a tuberculum meningioma is tilted toward and lying on the planum sphenoidalis and it goes up to the olfactory groove, then although it is a median lesion and does not overpass the carotid or optic chiasm, we prefer like to go supraorbital, because you will have not that much problem in opening and removing, especially if it is like soft, and you will have all the instruments to do that via the nose, but you have to create like a wide breach over the skull base, and you have to deal with two compartments, the planum sphenoidale, the tuberculum sellae, and the cella itself. So the reconstruction will be pretty tough, and you will expose the patient like to a tremendous high risk of CSF leakage post-op.
Another point which has become very hotly debated in decision making for transcranial versus endonasal is the visual outcome. And Dr. Schwartz's paper about both kind of surgeries from the same center favoring endonasal surgery is probably flawed, which criticism is come up on that paper, that transcranial surgery was for all comers while endonasal surgery was for selected patients, and therefore they can't be strictly matched. And recently Henry Schroeder has published with William Kuldwell their series of endonasal versus supraorbital or transcranial approach, and have shown that the visual outcomes have been almost equal in both the surgeries, while the rate of recurrence is slightly higher for endonasal surgeries. So do you have any comment on that? All the panelists, please.
So I think that's very valid. I think we're seeing from the very early thing where there was significant better in endonasal, we've seen that in fact, in the end, there's not a lot of difference as I showed. And as I say, and I agree with Henry, because of those that results of 44% deterioration in the open versus 0 is, it just does not make sense. So I think we're coming to this situation that these can be done equally well by experienced surgeon with an open or endoscopic approach. It's what you are comfortable with, what your preference is, and it shouldn't be one better than the other or whatever. And it's like, to me, Chandra, the Kawase approach. Do you use Kawase approach?
Yes.
I never used it in my life. Okay, I'm a skull-based surgeon. I never use a Kawase approach. Now, I suspect that there's an advantage to that for certain specific tumors of the anterior, the Pituitary, whatever. But I will do all my, retrosigma, and I'll get there. And I'm sure it would have been maybe a little easier using that approach. So same thing with here. If you can do an approach, and for me, for those very nice little cherry that's just sticking there for me, I will do the endoscopic approach. This year, just to let you know, because I went back to my thing this year I did 8, not a lot, 8 tuberculous meningioma. But that's a lot. 1 endoscopic, 7 open. So that tells you what the situation is. So the issue is, and that's why my question was, is it really worth it for that one? But for me, I'm doing, craniophryngiomas one day, I'm doing aesthesia neuroblastomas the next day, I'm doing juvenile angiofibroma. Now I see this little cherry. Of course I'm going to do it endoscopically. But if you're not doing that, you're not doing pituitary, you're not doing cranial, you're not doing that, it's a stupid idea for you now to do one, once a year you do this very difficult surgery that's done endoscopically. That's, to me, is the answer.
No, but I think you have made it very clear that it's for very highly selected group of patients. Dr. Nair, Dr. Sankhala, you have any comments?
Most studies, like Dr. Gentilli had shown in his slide, suffer from one big bias. That is, when we compare tuberculum cellae meningiomas to the transcranial group, we're comparing patient populations of more than 1,000 cases. And when we compare them to the intranasally operated patients,
Voice is not coming clear.
Yeah.
So what I wanted to say was that
it is better.
Can you hear me?
Yes.
So what I wanted to say was, in patients who undergo transcranial procedures, the patient population that is being compared is over 1,000 cases, whereas the series that are selected for choosing the intranasal case approach have case numbers of around 150 to 200 patients. So this itself creates a huge bias. The second thing is that it is almost intuitive that patients that were referred for transcranial procedures were primarily unsuitable for the intranasal corridor. So there must have been a surgeon bias at the time of selection. And even now, even in very experienced centers, factors like vascular involvement or lateral extension would automatically go into the the transcranial corridor. So these studies are not comparable, and to draw inferences would be spurious.
Agreed.
Yes, I agree with what Prakash said. I think it is the tumor characteristics which will lead you, to decide which approach you should choose. And whenever you are comparing, as he said, you are not comparing the right group of the patients. You need to really look at the tumor characteristic properly. So in a nutshell, if it's a small tumor, midline situated, and it is extending into the optic canals, is a case of endoscopy. While
we are running short of time, I would just like to ask the last question before we end. One of the things which nobody surprisingly mentioned today is what was described as the cortical cuff, which one group thought was very important in deciding should you be doing endonasal versus transcranial, while the other group said that it's of no importance. I would like to know all our colleagues if they would like to give some response to that.
I must say, Chandra, from the very beginning, it never appealed to me. That was not a major issue for me, so I was never into that game.
Okay, great. Domenico?
Yeah, I agree with Dr. Gentili. Like maybe you can have like this concept when first every one of us pretended to remove the tumor, like the most anterior tumor in the olfactory groove. So in that case, like opening the skull base, it can be, but for reconstruction, again, like some protection if you have like cortical cuff in the most anterior part that protects to opening up to the crista galli. And if you go to the crista galli, then unless you are like a very experienced ENT surgeon, you will never reconstruct that area.
Davide, do you do any meningiomas at all?
Yeah, we have done quite a good experience. At the beginning,
Would you like to comment?
Yeah. We at the beginning we were taking most of the tumors in the midline. Then we agree completely with Fred that the best option is take a tumor when it's midline in the tuberculum cellar region and not so big. So I think Fred covered the question very well, and I completely agree with him. Also, if at the beginning we were all doing a lot of endoscopic resection from the nose. But after then, olfaction preservation has been our prior idea.
Can I ask you one more question, David, just to end the conversation, because you have some experience. For the lateral extensions, have you ever tried transorbital endoscopic approach in these tumors?
Depends. Yes, we have done quite a number of transorbital resection. But this needs a very precise indication, because we are treating tumors which extend mainly inside the orbit. And if there is something outside the orbit, we can go, but it's very limited portion of the tumor. And it is not so easy to explain just in a couple of minutes which are our indication. We use transorbital, transpalpebral approaches mainly in recurrent tumors, in meningioma recurrent with a great invasion of the orbit.
Thank you very much. And I must thank David, Domenico, and Fred for very good talks and very good question answer session. And I would leave the rest of the proceedings, I think, to Dr. Sankhala and Dr. Ashis.
Thank you, Chandra.
Thank you. Thank you.
Ashish,
Thank you.
can we conclude this meeting then?
Yes, we should conclude. I thank all the speakers. That was a great session, and the question answer was really very, very interactive, I would say. We learned a lot, in fact, and thrashed out a lot of controversies also. So that was really educative in the true sense. And I think this was one of the best sessions that we had, to be very honest. And I once again thank our foreign speakers specifically for bearing with us at this hour of the day in their country to sort of educate us. And with this, I would be happy to announce that our next webinar 6 is on 17th January, which is Sunday. But this time we are going to a different aspect. This will be on endoscopy with the spine, with endoscopic lumbar discectomy versus microsurgical discectomy. And second one is going to be endoscopic treatment of lumbar canal stenosis. So this would be something new. Thank you very much.
All right.
Thank you, Chirio.
Thank you, everyone. Ciao, everyone. Have a
Thank
great
you.
Sunday. Ciao, ciao.
Hello, sir.
Yes.
Sir, we would like to thank the audience who joined us.
Yes.
In spite of a parallel neurosurgery program going on. I would like to inform you that 218 doctors joined our webinar today. 218 doctors joined the webinar today from 5 countries. We got 18 logins from 5 countries. 18 logins from 5 countries. And we would like to thank on behalf of Health and You our international speakers, Professor Solari, Professor Locatelli, and Professor Gentilli. Professor Gentilli, I should take my hats off. Getting up at 5 o'clock, you are so energetic, so fiery, and the entire speaker group kept us oscillating from transcranial versus endoscopic and endonasal surgery. And I would like to thank Professor Deopujari sir for his fantastic coordination, very insightful questions to have a 360 degrees overview of this topic, endoscopic transsphenoidal surgery. And would like to thank Professor Sankhala for conceptualizing this webinar series, for which we have 5 episodes till now, and going on to the 6th episode. And Dr. Pathak for coordinating the entire episode. So thank you very much for giving us this opportunity to carry this. Thank you, audience, for joining us, and look forward to the 6th episode of Endoscopic Neuroendoscopic Society. Thank you very much. On behalf of
ciao.
we would like to thank all the foreign speakers and audience that joined us. Thanks a lot.
Sure, we'll see you again soon.
Thank you, sir. Thank you very much.